I'm Dr. Arnold Wheel, and I practice in Atlanta, Georgia. I have a non-surgical orthopedic practice and also specialize in pain management. Today I'm going to be talking about disability assessment and impairment and disability evaluations. Impairment is defined as a deviation from normal in a body part or organ system and its functioning. Conditions that interfere with activities of daily living are an impairment. Impairments can be defined as temporary or permanent. And a permanent impairment is one that's unlikely to change in spite of further medical or surgical therapy. Impairments are typically given as a percentage, and this percentage comes from the guides to the evaluation of permanent impairment. It's referenced typically as either a partial impairment, total impairment, a temporary or permanent impairment. A disability is different. A disability is defined as an alteration of an individual's capacity to meet personal, social, or occupational demands because of an impairment. This is typically a restriction or lack of ability to perform an activity in the manner considered normal for a particular individual. So whereas an impairment would be the loss of ability of a body part to do something, the disability is what that individual cannot do because of his or her impairment. A handicap is really an impairment that substantially limits one or more of life's activities. So a person needs to compensate in order to perform that activity. So somebody who's handicapped is unable to do a particular type of activity that they may want to do, and then has developed a compensation mechanism in order to allow them to do that particular activity. The Guides to the Evaluation of Permanent Impairment is the standard text for impairment and disability evaluations. Currently, we utilize the 5th edition, although new editions may come out at some point. What we do is we take charts and tables that are referenced in the guides, and we plug in certain numerical values based upon an examination of the patient to get objective, not subjective, data and ratings. The guides, as the standard utilized text, is objective, it's authoritative, and it's widely used by all physicians who perform impairment and disability evaluations. So the structure and use of the guides, again, this is the medical assessment of impairment. And the criteria includes reviewing office and hospital records, history taking from the patient, and again, the judicious use of diagnostic tests when available and when necessary. And then finally, the physical examination. These are the components that we utilize to obtain a rating based upon the guides to the evaluation of permanent impairment. So what are the rules for the evaluations? Well, we need to estimate the extent of the patient's primary impairment. We use tests of consistency to validate that we're getting a consistent effort from the patient. We use the combined values chart in the text, again, to get the actual numerical value for the impairment rating. And we obtain measurements. Sometimes we take into account pain as a variable, and again, adjustments for the effects of treatment or lack of treatment. So these are all part of what we utilize within the guides to obtain an appropriate rating for impairment and disability. Records and reports. Again, the medical evaluation. We perform an evaluation of all the medical records, take a history from the patient, and then we dictate and perform a narrative history outlining everything from the initial injury to the processes that brought about the injury, mechanism of injury, to what's occurred during the treatment period of time, and what the patient is complaining of today, and where we are in this process. The discussion of diagnostic testing is also utilized, again, in any prior treatment. All these are referenced in our report for an impairment and disability evaluation. At that point, then, we analyze the findings. We try to incorporate everything that we have uncovered through history and review. And after analyzing the findings and taking measurements in our physical exam, we obtain the percentage of impairment criteria from the guides and the chart. And as I mentioned before, they are objective. It's not a subjective part on my part. And again, any impairment rating should be consistent from one physician to the next. So if we go through and look at the various types of impairment ratings we can do, we'll start off with the musculoskeletal system. Here we can look at and evaluate the upper extremity, lower extremity, spine, and pelvis. And each of these areas are looked at as a unit of the whole person. So when we assign an impairment rating, it's an impairment of, let's say, the spine as a relation to whole body. But it's much more pertinent to give each impairment for the particular body part. It makes much more sense, and it's relevant as far as applying the appropriate disability. So let's start off with the upper extremity. Again, looking at impairments, we're going to evaluate the upper extremity from the hand, wrist, elbow, and shoulder. We take each body part, we look at range of motion. If the motion and movement is within full range of motion, looking at flexion, extension, abduction, adduction, internal rotation, external rotation. And we go back to the book, to the guides, to see what the normal values are and what the values are for the particular patient. Lower extremity, very similar. Again, looking at foot, hind foot, ankle, leg, knee, hip, all the joints of the lower extremity. Again, each time we do an impairment rating, we must take measurements of each joint in that particular extremity that we are assessing. The spine is another area where we commonly are asked to do assessments for an impairment and disability evaluation. So again, the spine we break up into the individual segments of the spine, whether it be cervical, thoracic, or lumbar. And of course, in the lumbar spine, we closely assess the coccyx and sacral areas as well. So again, each impairment rating, each time we do a rating, we're taking the particular area of the body. In this example, the spine, we're measuring range of motion. If we're doing cervical spine, we measure flexion, extension, rotation to the right, rotation to the left. Okay? We compare the measured values to the norm. We can use goniometers, we can use inclinometers, we can use range of motion assessments, but nonetheless, we have to obtain the reproducible numerical value and compare this to the norm. Pelvis, again, looking at pubis, ischium, and ilium, and again, assigning appropriate impairment ratings based upon the guides to the evaluation of impairment. So how do we do that? Well, I've mentioned before we obtain range of motion values, but certainly it starts with a cosmetic evaluation. We visualize the particular impairment. We look at the body part, see, document, and state what we see on our exam. And then we do a functional evaluation as well. The use of the body part. Are they able to use that arm to dress? Are they able to use that arm to feed themselves? All right? So the most practical and useful approach to evaluating any type of digit impairment is to compare it with a loss of function that results from an amputation. That's really where the guides take their origin from. Looking at an amputation, if that existed, and the loss of function associated with that. So in the musculoskeletal examination, we look at restriction of motion, whether the active motion takes precedence over the passive motion. In other words, if the patient cannot move their arm and flex their elbow themselves, can the examiner, can the physician do it and move that joint passively? Again, the range of motion measurements are rounded to the nearest 10%. And we go back to the guides specifically look at range of motion in percentages. So again, if my range of motion is 37, but the guides mentions 30 and 40, I'm going to round it to the 40% or 40 degrees. Okay? And as I mentioned, often we can measure the range of motion and movement with a goniometer. All right? So the musculoskeletal examination then is going to look at range of motion, sensory loss, and again, the abnormal motion that we find on exam is going to equal the percentage of impairment for that particular body part. So the range of motion then that we obtain is measured and compared to the graphs and the guides, and the percent loss is determined from the tables and then reported in our evaluation report as an impairment rating percentage. So in looking at the reporting of impairments, the regional impairments are combined to obtain impairment of the whole person. So for example, if I have a patient with a neck injury and a low back injury, I'm going to assess and obtain an individual impairment of the neck, and then I'm going to assess and obtain an individual impairment of the lumbar spine, and then I'm going to combine these through charts in the impairments guide to obtain and get to the impairment of the whole person. So I will determine each impairment of each region, such as the hand or the wrist or the elbow or parts of the spine. I'll use the combined values chart then to combine these impairments and use tables to convert the impairments of the upper extremity in this particular case to the whole person. So it's very important if you are requesting your physician to obtain an impairment rating to specify whether you want an impairment of the particular body part, i.e. impairment of the lumbar spine, or whether you're more interested in an impairment of the whole person. So how that impairment of the spine relates to the whole person. For example, if somebody has a very significant impairment of the elbow, and their impairment of the elbow is on the order of 30%, that may be only a 5 or 7% impairment of the whole body or the whole person. So it depends upon what you're particularly looking at into what we provide for you as part of our impairment rating. Most of the time we're asked to assess and provide an impairment rating for a particular body part and not convert it to the whole person. Well, there are certainly other factors to consider when performing an impairment rating, and in this case, in addition to obtaining range of motion. So if you look at the lower extremity in particular, there are other factors we might consider. For example, is there a limb length discrepancy? Is one limb longer or shorter than the other? Is there abnormality in gait? Okay, is there muscle atrophy that we can see on the evaluation and part of our examination? All these things may affect the impairment, and although they are more subjective, they still can be used to integrate into our impairment rating. Again, manual muscle testing is used to determine strength. Peripheral nerve injuries may be documented, and sometimes we'll do a nerve conduction study to evaluate for peripheral nerve injuries. And also vascular disorders can certainly contribute and be added in and considered in addition to range of motion for impairment of the lower extremity. And finally, pain. Sometimes pain is used to, again, help us with our assessment of impairment based upon the particular injury and body part. So let's talk about spine disorders. Again, spine disorders is a little different as far as our impairment. We use diagnoses-related estimates, and there are 8 categories that we look at. What we do is we look at the different categories to determine what our impairment rating may be. In the cervical and lumbar spine, the diagnosis